But when does it become serious, right? Because a phase 4 has to go through a phase 3, and a phase 3 has to go through a 2, and a 2 is once a 1. So at some point, we all got to take it seriously and start to realize that we're the experts. Postural alteration or postural alterations, I actually take an X-ray. So why does Dr. Ed take X-rays of 4-year-olds? Well, I got to give you a little bit of background. So one of the questions we've gotten over the past 25 years or whatever, actually maybe a little less than that, since 2000, 22 years, is like, how did you guys grow so big so fast? Okay, so within a 2-year period, how can you go and hit 2,000 a week? How can you go from 0 to 1,000 a week in that period? And I'm going to let you in on it. It's because we were all about people. We were all about changing people's stories, changing people's lives. And for us, it was really, really about life and death. And it was all about the seriousness. So I took it personally, okay? And I still do take it very, very personally. I don't care what people think about me. That doesn't, hit my radar. But what I do and why I do it, I take it very personally. Okay. And the reason why is because of the stories. And I'm going to just share a little bit of a story. I posted yesterday this post on Facebook. And it was really cool. It was the boys got to play golf with Papa Kenny, and Papa Kenny, they got to play at Loon Lake. And 50 years ago, Papa Kenny was the 1972 Loon Lake Golf Course League champion. And so they got to hang out with Papa Kenny, which is really, really great. And we were just wishing our U.S. friends and family members just a happy Memorial Day. But that doesn't tell the full story, okay? So Papa Kenny didn't play golf that day. He wasn't able to play golf with the boys. This is the first time Papa Kenny misses a golf outing with the boys. Now, he didn't miss the outing. He was a ride-along, but he couldn't play. And the reason why he couldn't play is because he can hardly move, okay? So Papa Kenny is 83 now, 84 years old, and all he does is shuffle steps. He shuffles, and he's got a massive amount of spinal stenosis at, guess where? If his legs are going, guess where the spinal stenosis is? Take a guess, Ange. So yeah, so L4, L5. I'm picking on Ange because she's one just popping up on my screen. So I might pick on you some more, Ange. So it's massive spinal stenosis, okay? And it's hard. And I know you guys have gone through it, and we're getting to the age where I lost my dad 2 years ago. And that's why these special, these special moments are really special to us now, because we're not missing family moments, or we're trying not to take for granted. But and it's a great story of like, oh wow, they're with grandpa, but the grandpa should be walking, grandpa should be playing golf, and grandpa's been dealing with this spinal stenosis for like 30, 40. I've been hearing about it for 25 years. We've been married for 26 years. I've been hearing about it for 25 years. Okay. And he always asked me about what stretches. I've been sending him to the chiropractor. Some of the chiropractors I actually mentored when I was in school. And I'm saying, okay, once a week, twice a week for the whole year. And even these chiropractors were uncomfortable with this. They would say, well, that's more than I would recommend. Like, no crap, it's more than you would recommend. But look, the reason why. Now we're 25 years later, and Papa Kenny can still be with the boys, but can't play with the boys anymore. That was the post I did before that was April 28th. Sadly, one of the things that keeps me passionate and focused with respect to spinal reconstruction is watching some of our closest family members suffer and lose the ability to do the simple things they love and that we love doing with them. Posture is the winner of your spine, and your chronic spinal pain a predictor of your future mobility. Your future mobility is directly connected to your future ability to not only do the things you love, but to do them with the ones you love the most. Okay, I take it personally. I always have. Okay, Harrison's cervical curve. Actually, I'm talking about, interestingly enough, the kid that when you see the pre and post X-ray down below there, his name's Harrison. Sir Harrison's cervical curve was restored in his 20s, changes his story for his 50s, 60s, and 70s, and 50s. I don't know if I said that, and beyond. Okay. That's what we got to get. You bring back a curve in the 20s, it changes. But when did Harrison lose his curve? Well, according to, trauma, he most likely lost his curve during a traumatic event. I believe it was ski racing, actually, in his grade school years. Okay, that's why pediatric cervical curve reconstruction is really important. Now, you think, wow, that's great. I wish I had. Well, I know you guys don't wish you had a Papa Kenny story, but listen. So Papa Kenny is Holly's stepdad. Okay, Holly's father, okay, actually had spinal surgery in South Dakota at Stanford Health. This is like a super world-class hospital. They valet your cars for you when you drop. You're a visitor, they valet your car, okay? So his surgery was about $120,000. And what they did, he's had massive low back pain, massive sciatica, and they went in and they cut a disc out, removed part of the lamina, and now he's taken less Oxycontin. He still is taking Oxycontin, but less, okay? And he's actually able to move a little bit better than he was, okay? $120,000. He's a truck driver. You know how long I've heard about his low back pain and his sciatic? And I'm going like, hey, Jim, let's get rid of the cowboy boots. Like you're wearing out the heels on the inside because he's shuffling around and he can hardly, massive spinal stenosis. I've been hearing about his low back pain, okay, for 26 years. We've been married for 26 years, 26 years, okay? And if that doesn't hit home, Karen, okay, so Papa Kenny's wife, Holly's mom, okay, Karen went under spinal reconstruction surgery, okay, 5 weeks ago. Can't make this up, eh? 5 weeks ago, spinal reconstruction surgery at the Mayo Clinic. You guys hear about the Mayo Clinic? One of the most known hospitals in the world, the Mayo Clinic in Rochester, Minnesota. Okay, so they actually, Karen's had a scoliosis since grade school. Okay, they just remember her being crooked in grade school. They don't know exactly when it started. Was it idiopathic? Was it trauma? We don't know. The researchers are still out, right? 50-50. Where does it come from? Okay, whatever. But she goes to undergo. So what's really cool, okay, is that she actually had the scoliosis and she had 2 compression fractures. Now get this, Angela, you hearing me? Okay, so if I have a straight line, okay, and one of her apex curves, or lateral apex curves in the lower thoracic looked like this, okay, where do you think the compression fracture was, or the 2 compression fractures? Where do you think they ended up being? Is it up here? Is it down here? Or is it what? Right there. Why? Because of the load moment, okay? It's a load moment. That means there's increased load over time that's breaking this down. The cool thing is with the compression fracture, now they're able to go in with the balloon, okay? They go in with the balloon and they actually pump up the balloon. It's like jacking up a car. They literally pump up the balloon and it jacks up the compression. Is that pretty cool? That is way cool, right? Way cool. So they jack up the compression, but remember, this is the lateral. She walks around flex less than 45 degrees. Okay, she can't get past 45. She walks around like that. Okay, pre-surgery. So they actually pump up the balloon and then cement the vertebrae. Okay, once it's up, they cement it. And so what's happened to her? What she looks like, her spine looks like right now. Okay, it still looks like this. Okay, still looks like this. She still can't get up over 45 degrees. But what she's able to do is move her feet a little bit more, move around a little bit more, and take less opiate derivatives. That's what she's able to do. So on both instances, it's actually decreased a little bit of the opiate derivatives. Okay. So what am I getting at? When we were down there visiting, everything revolves around, like Papa Kenny loves fishing. He can't even get in. We're talking about fishing, Pascal. He can't even get in a fishing boat. Okay. Can't get in anymore. I've never seen him like this. Can't get into the fishing boat. So I actually rented a pontoon boat, okay, for the week so we could fish, and Papa Kenny can fish without worrying about, like, going head over, tea kettle, right? And he wouldn't even get on the pontoon boat. Why? Because he's worried about actually his mobility. 5 minutes to get out of a car into a car. So why am I sharing this? Well, at some point, so they would say, all the doctors would say they have very, very serious spinal conditions, all three of them. But when does it become serious, right? Because a phase 4 has to go through a phase 3, and a phase 3 has to go through a 2, and a 2 is once a 1. And that 1 could have started in the 20s, could have started in the 30s, could have started in grade school, could have started as a 4-year-old. So at some point, you guys, and we all got to take it seriously and start to realize that we're the experts. Okay. And I'm thankful for that awesome surgery. And you know what? Jim's surgery for his low back, laminectomy. And before they used to, in the 80s, they would actually leave a foot-long incision, and infection rates were through the roof, and it was a 50-50. Now, are they getting better at microsurgery? Absolutely. But you know what? Spinal reconstruction shouldn't happen in 60s and 70s. I'm thankful for it, but it shouldn't happen then. Spinal reconstruction should happen in grade school by a chiropractor who specializes in it. Okay, or as a 4-year-old, or as a teenager. Okay, and these surgeries are hundreds of thousands of dollars. So hopefully, the family stories get you jacked up enough for a few more reports, right? But I'm going to share something with you. This is the coaching nugget here. Okay, is that a long time ago, I realized that my only deal was I'm going to stand up and rip reports. And my report is I'm just sharing what I believe, and that is it. It's like, how do I rip a report? This is how I rip a report. This is how I do my reports. This is the level, this is the intensity, and this is just me. I'm not even like, this is my report, okay? But the promise I made is I'm not going to be able to control how I'm really good at conversion and reconversion rates and stuff like that, but that's not what I focus on. I focus on just sharing what I believe and just being all about it. That's it. And I know from the statistics that 70 to 80% will actually follow through with my recommendations. 20 to 30% don't. And I can't control it. But this is what I made a promise to myself and to God, is that I will never, ever have nobody will ever be able to leave my report and say, nobody ever told me about this. Nobody ever. See, because I was telling Papa Kenny and Karen and Papa Jim about their low backs for the past 25 years. Okay. But nobody prior to that told them about anything. And so that's a promise I made to myself. And if you guys want to see more kids, when you rip a report, the parents should be saying, I want my kids checked. And to help them out with that, you know what you start doing? Start doing X-rays on kids for free. It takes moments of your time. It's all digital. It actually, before, used to cost us money because of the, the silver and the, all that processing and stuff. It doesn't even take us money anymore. So you go through your, your computer software faster. You got to, re-up the, whatever. Okay. But do it for free. Just do it for free. And this is the kicker. It's not about them starting care. It's about allowing the parents to make a decision about something otherwise they wouldn't even know about, and make a decision potentially 10 years, 20 years, 30 years, 40 years prior to any symptoms even starting. Give them a shot, give them a chance before it's too late. Pascal, it's all yours.
I don't know if I could follow that up, Ed. That's some serious passion. I love it. In all seriousness, though, just on the topics that you mentioned, I X-ray all kids if their parents are under care, especially any kid that comes in, parents under care, no charge for the x-rays. Let's get your kids checked. Let's get your kids checked. That's a conversation we have in the clinic with all the parents. We talk about in our reports. Let's get your kids checked. And hopefully the information that I present today about the pediatric lordosis will help to convey that message and get you guys giving better care to youngsters and knowing when, how to x-ray, when to use traction devices with them. Okay, so let's see, where is my screen share here? Screen share. Okay. Can everybody see my screen? Just give me a thumbs up in the little screen there. Good, everybody can see my screen. Very good. So the pediatric lordosis. So why are we talking about pediatric lordosis today? Well, all the reasons that Ed stated, obviously very passionately, but also because we asked, I know Doctors Ed and Dr. Yuri had sent out a surveyor to ask for topic suggestions. What did the Warrior doctors want to learn about this year? And this was a very popular topic. There were a number of requests to learn about the pediatric lordosis and discuss the pediatric lordosis. So today we're going to dive in. Here's what we're going to talk about: X-ray analysis and measurements of the pediatric cervical spine. Indications on how and when to use cervical dental roll for kids and or traction in office. I'm not sure how many docs listening would do in-office traction. And then we're going to review the pediatric cervical curve corrective literature. So looking at case reports, case reviews of kids that have done corrective care, had the improvement in the cervical curve, and what were those outcomes for their health? What did it change in either, symptoms of pain and or other health conditions? And then we're going to also discuss what's called an epidemiology study. There's a great study that was released by Dr. Curtis Fedorchuk last year with a few colleagues about the prevalence of cervical subluxations in the pediatric spine. So it helps to support taking x-rays even in the absence of symptoms. All right, so here we go. Let's dive in. Let me get my handy dandy pen here. Okay, so first things first, when we talk about the adult lordosis, we've covered it in detail. If you've been following these for a while, thank you for being on again. Thank you for being loyal to these and upping your game as it stands in regards to spinal reconstruction. But if you've been on with us for a while, we've talked about the adult cervical lordosis a ton. And that is because there's a plethora of research out there supporting what the normal spine should look like, discussing the different measurements on how to get that, how to measure the normal cervical spine, what the variance might look like, the PTSIA. We talked about, the tangents of C7 and T1 relative to vertical. I mean, we have so much information regarding the adult cervical lordosis because it has been so well studied. Unfortunately, the pediatric spine has not been well studied. So there is much less information out there. And so today we're going to review the information that is available, or the best information that is available. We used to think, and I've heard it myself, even back when I was in school, that crawling around on the hands and knees was how the cervical curve developed in children. And I'm not saying that maybe it's not still a part of it, but we have x-rays now, we have proof, we have advanced imaging that shows us that the cervical lordosis actually begins to develop at 7 weeks in utero, and that the majority of the lordosis is developed by 9.5 weeks in utero. Okay. Then when we start looking at children, toddlers, we know that the lordosis is extremely prominent from the ages of 2 to 4. Then we have a steady decrease in that neck curve from 4 to 9 years of age. And then from 10 to 18, the lordosis will steadily increase until it approximates adult values. So the biggest thing I want you to take away from this is that there is a huge amount of variability in what the neck curve looks like in kids. So I took this chart right here out of one of the Harrison studies. It was like a review of the literature looking at curve correction in kids and correcting cervical lordosis in children. And they basically presented the best evidence that's out there looking at what should that curve be for the kids. Okay, so there's a lot of information. Let's only focus on the columns that are outlined in yellow. So 1, 2, 3, and 4. Okay, try and ignore the rest. The very first thing you could see age. So it's just 2, 3, 4, 5, 6, all the way up to 8 years of age. Okay, so every year we have a column. Then we come here and they're looking at the average curve. ARA stands for curve. The average curve C2 to C7 for all the different ages. And I want you guys to notice that if we go down here, there is not one value that is the same. It differs at every single age. Okay. And again, per what I just told you in that, you can see that, from the ages 2 to 4, there's about 30 degrees of curve. Then it drops down to about 21, 22 degrees of curve around 9, 10 years old. And then it steadily increases back up until it gets closer to the adult values at 18 years of age. This column is just comparing to the adult curve. The adult curve is very simple, 42-degree lordosis across the board. And then lastly, I don't know how important this one is, but this column is just showing us the difference between the adult curve and the pediatric curve at that given age, right? So for 2 years old, a 42-degree neck curve for the adult, we've got 31.7 at 2 years old. So there's about a 10-degree difference between adults and a 2-year-old in their cervical curve. Takeaway message from this chart: you need to know these values if you're going to be X-raying and working with kids. Now, if you use a posture array, if you use a software like Posture Array, which we use in our office, it's wonderful because I don't have to memorize any of these values. As soon as you type in, the patient's age in Posture Array has all of these values already inputted into their system. So once you calculate the child's curve, it gives you the child's curve value and it compares it to an age equivalent. In other words, it pops this value in here. So it gives us the percentage removed from normal per the age for the child. If you're not using the software like Posture Array, pull out your phone right now, take a screenshot, take a picture of this, write these values down, keep them in your office. These are the values that you want to know, okay? I'll give you a second for those. I see a couple people pulling out their cell phones. Take a picture. There are your values. Now, if you've been with us for a while, you know how we measure a curve. I know that there's probably some docs that are new on here that maybe haven't been on any of the webinars. So I'm not going to spend too much time discussing this because you can always request or go back and look at the previous webinars, especially the one where we discussed measuring subluxations on cervical X-rays. We talk about how to measure a curve. But very briefly, for those of you who may have never seen it, we take the lateral cervical film, you take C2 and you take C7. We put what's called a tangent line behind C2, so all the way down. You put a tangent line behind C7, and that creates that intersecting angle. You measure that, and that is your cervical curve, C2 through C7, okay? So we measure it exactly the same way for kids as we do adults. The only difference being that the values change from 2 to 18 years of age. All right, moving on. So that's very simple. We know how to, oops, why is my screen here frozen? There we go. So we know how to measure it. We know that there are varying values, but now that we know the values, we know how to measure it, the next step becomes, okay, well, when do we start X-raying kids? When do we start using a cervical dendroll, doing cervical traction? How do we implement this in practice? And Dr. Ed mentioned, or he showed us that X-ray of a 4-year-old, which actually ties in perfect to the presentation. I love that he put that up there because we're going to talk about 4 or 5 years old is really the age where we're starting to look at postural problems. We're starting to take X-rays on almost all kids because we can now start doing curve correction. And it's not to say that I won't X-ray a child that's younger than 4 years old, but generally if they're not standing, if there's in the absence of trauma or in the absence of significant problems on a child that's less than 4, I'm not going to X-ray them because I'm not going to do any traction with them. If I suspect trauma and I want to see what's happening in the cervical spine because it's going to dictate how I adjust that patient, fine, I will absolutely take X-rays of a kid that's younger than 4 or 5. In the absence of trauma, if we're just doing supportive care, maintenance care for a kid until we can take X-rays to look at corrective care, I don't X-ray kids if they can't stand in a normal position in front of the bucky. Okay, so here's the data that supports that. Here is a cross-sectional study that looked at 1,084 children. Okay, so this is 1,084 children aged 4 through 12. And again, this is Dr. Deed Harrison and his colleagues. They looked at these kids, and their hypothesis was that from 4 to 12 years old, as these kids are going to school, their posture will break down with time. The more time they sit in these, bad ergonomic chairs, the more time they're looking at a computer, a cell phone, a tablet, as they're growing, if they're not doing something to reverse it, their posture will break down. And sure enough, the conclusion is that yes, there's a linear trend from 4 to 12 years old that we see in school-age children that shows increases in forward translations, right? We know that forward translation of the head is a valid subluxation measurement, shoulders, pelvis, and knees. Okay, for the purposes of this conversation, we could just focus on the head, but starting at 4 years old and up, we're starting to already see those shifts and translations of the head in school-age children. Okay, so you have your first indicator to start screening them and looking at them, because we're going to be doing traction on our patients if we have two indicators: one, forward head posture, and then two, some form of subluxation on X-ray, which could be a loss of curve, or it could also be what's called an anterolisthesis. So we're going to talk about this study now. So we've got, a postural indicator. We know that most of these kids are starting to show these problems at school age, even in the absence of symptoms. And now you see a postural indicator, or if there's trauma, you're going to take an X-ray. And now we're going to analyze that lateral cervical neutral film. Now, I want to be very clear. We've talked in the past about a loss of curve and anterior head translation on X-rays as being valid measurement tools for subluxation. And yes, they are. For this study, though, the only thing that was measured, I'm going to skip ahead a slide, as a subluxation measurement was slippage of bones. So C3 over C4. Okay. And actually, funny enough, we talked about stenosis. I think it was Papa Kenny there. He had stenosis. Well, what is stenosis? Oftentimes it's due to this, L4 slips forward on L5. Well, so this is a very valid also measurement of subluxation, and it is widely accepted around the world. In other words, you start talking about loss of cervical curve and anterior head translation, it's still largely debated in different arenas in healthcare. You talk to any spinal professional and you ask them if it's a problem. If one bone slips forward on top of another bone, the answer is yes. So for this research project, Dr. Curtis Fedorchuk and his colleagues used slippage of one bone over the next, an anterolisthesis or a retrolisthesis, so any shift forward or backwards. That was their measurement tool for subluxation in this study. So if we could say, had they included loss of curve and anterior head translation, the results and the numbers would probably be even way higher than we see. Okay, so I want to make that perfectly clear because I'm sure somebody will ask me afterwards. So what they did, and this is an awesome study because, again, not in a chiropractic journal. This is in the Journal of Pediatric Radiology. It was released in 2021. It is a very new study. And they're talking about the prevalence of subluxation in the pediatric spine. So their inclusion criteria, kids that were 0 to 17 years of age that were receiving care, seeing the chiropractors for some form of care. They looked at 342 lateral cervical films on these youngsters. And their criteria were, and this is per, not what they decided, this is what large-scale research has told us about antero and retrolisthesis. Anything greater than 2 millimeters, so 2 millimeters to 3.4 millimeters, is considered a moderate amount of instability. Anything above 3.5 is considered basically grotesquely unstable or on the risk of complete instability. Okay, here are their results. Of all the kids they x-rayed, and only using this form of subluxation measurement, 21% of them had a shift, right? So one bone slipping forward of more than 2 millimeters, right? So you have 1 in 5 kids that had just this form of measurement of subluxation alone. 1 in 5 had slippage that was greater than 2.0 millimeters, okay? Now here's the kicker. Of those kids that had, anterolisthesis or retrolisthesis, over half of them had no musculoskeletal complaints. So again, here's a perfect study to show us that even in the absence of symptoms, if you have abnormal posture, if there is trauma, or you have reason to believe that something is happening in the cervical spine, we should be x-raying these youngsters, because problems like this left unchecked 40, 50 years down the road lead to someone sitting in a golf cart, not being able to play the game with their kids, because this will continue to break down through life. Even above 3.5 millimeters, there was 8 kids that had slippage of higher than 3.5 millimeters. So 8 kids in this bunch had a completely unstable cervical spine, and 5 of the 8 had 0 musculoskeletal complaints. That, my friends, is a problem. Okay, and again, this is another one that's going to give us support on why we would start x-raying around 5 years of age. This is the data, okay, from their study. So the 342 kids, this is just showing us how many per age group they found. Okay, and so you can see here at 4, there were none. Starting at 5, you started to see the anterolistheses. These problems start happening at 5 years of age. Okay, a concept that we're going to discuss briefly, but not to confuse anybody, but this is important because, as Dr. Ed mentioned, we are positioning ourselves as the experts when it comes to conservative care of the spine. We want parents to bring their kids to us, to be able to treat their kids, to be able to give proper care to their kids. But we have to be very careful when we see some of these problems that we're not, telling a parent that their child has upper cervical instability when it is just normal bone growth patterns in a cervical spine. So this is a concept called pseudo-subluxation. So this is not really an anterolisthesis. It happens in kids that are growing. And as I understand it, it's because C2 develops differently than C3 in the bones below. So a pseudo-subluxation is when it looks like, just in this case here, this is a perfect example. You see C2 slipping forward of C3. And let's just say, it measured above 2.0 millimeters. Well, you want to find out, is this a pseudo-subluxation? In other words, is it sort of a projection distortion based on bone growth? Or is it truly C2 slipping forward or backwards? Well, our follow-up measurement is to look at the back of the bone, because if it is a true subluxation, C2 is slipping forward in its entirety. And so how they do that is you go to the posterior, so the spinal laminar junction. So there is the spinal laminar junction of C1. You go to the spinal laminar junction of C3. Sorry, I'm trying to draw this freehand. And then you connect that yellow line between the two. If your C2 spinal laminar junction line is touching it or sits behind it, well, C2 has not slipped forward. It's just a projection distortion, AKA pseudo-subluxation. This is not a real spinal problem. So don't go tell the parent that their kid has had some kind of trauma or that spine is unstable, because if they take that to another radiologist, a medical doctor, or a spinal surgeon, they're going to be like, no, that's just normal bone growth. That person doesn't know what they're talking about. Okay, so again, if you want to double check it, you put a line between the spinal laminar junction of C1, C3. If the spinal laminar junction of C2 does not cross that yellow line, it is not a true subluxation. It's a pseudo-subluxation. And Dr. Curtis Fedorchuk and his colleagues state right here that in all those x-rays, they saw 12% of the kids had this. So it is pretty common, okay? So pay attention. You need to know about that. Okay, let's talk about some of the research now behind correcting curves in kids. Correcting a curve in a kid is very different than correcting the curve in an adult, okay? This is a case series from CBP. Here are some of the highlights from the text. I just want to read them to you because this is better than I could say it myself. The pediatric change in lordosis is estimated twice as large as for adults. In other words, they're going to change twice as fast as adults. Why is that? Well, because they're less stiff. They've had smaller injuries, less injuries. They have a smaller spine. It's weaker and it's more amenable to change. But that brings us to the very real possibility of overcorrecting that little spine. The average change on this case series, okay, so I noted it here. The average change was 29.6 degrees over 35 traction sessions. So in that little kid's spine, they're getting almost 1 degree of change per traction session, okay? So that means that we have to check in with those kids sooner. Maybe take an x-ray of their neck or whatever area you're tractioning faster than you would with an adult. For me, in my clinic, it's 20 visits. After 20 sessions, 20 visits, and especially if they're doing their traction at home consistently, I retake an x-ray of the neck to see where they're at, because they will change much, much faster than an adult. So here are some of the case studies. So to point out, a lot of these case studies, I'm going to show you one, they were overcorrected for maybe a few reasons. Not because the chiropractor didn't check back early enough, but prior to the research project that I showed you early on, where we saw all that variability in the pediatric lordosis, it was simply assumed that a kid's neck should look like an adult neck. So in other words, let's put 42 degrees of curve in there. And maybe one day, as more research comes out on the pediatric lordosis, we might find out that maybe, yeah, that pediatric lordosis should also be 42 degrees. So back in the day, a lot of these chiropractors were trying to get the neck up to 42 degrees. And so now we know that there's a variance and we should be trying to get it closer to the normal for that age. But a lot of these case studies I'm going to show you, they were overcorrected and in a very short time frame. However, I will say that if we're talking about lack of curve, anterior head translation, cervical kyphosis, or too much curve, we're still going to go with too much curve. It's still better to overcorrect the spine than not correct it at all. Because in every single one of these cases, even though there is, some overcorrection of the curve, these kids are still doing remarkably well. And all of these health symptoms completely disappear after they get this corrective spinal reconstruction. So the first case study is resolution of chronic ear infections, neck pain, headaches, and sinus infections in a child following corrective care. So it was an 8-year-old that had 3 years of complaints of ear infections, headaches, neck pain, and sinus infections. So she did 29 visits, so it's not a lot. And every single time, these kids are always doing the same thing: adjustments, exercises the best they can, and traction. This was traction in Dr. Curtis Fedorchuk's office. So it was like on one of these Gambali type chairs, or, extension type of regainer chairs. And this child's lordosis went from 6.9 degrees to 31 degrees in 29 visits. So 31 degrees is, again, slightly overcorrected for an 8-year-old. However, there was complete resolution of the headaches. So even though it's overcorrected, the child did better. Next case, the pediatric lordosis we are looking at. There we go. Did I go too far forward there? Sorry, I get a little bit of a delay here. I don't know why it's, there we go. Let's try that again. Okay, resolution of headaches in a 13-year-old. So here's a child that had headaches for 4 years. This is a 13-year-old child. And this child saw the same chiropractor, Dr. Curtis Fedorchuk, and they did 6 weeks of care. So not very long, right? 6 weeks of care. They didn't state the exact number of visits. They just said 6 weeks in this paper. But let's assume roughly 3 times a week, you're at 18, again, close to 20 visits. The child's lordosis cervical curve went from 3 degrees to 43 degrees. That is a very fast and very large correction. Again, probably too much curve for this age. However, complete resolution of the headaches, and the child was doing much better. So still a positive, but remember, be very careful not to overcorrect these kids' spines. Here's an 11-year-old that had asthma, so troubles with lung function. She had allergies, itchy skin, leg cramping. She had seen previous chiropractors or previous professionals without any success. This is a case where it was a cervical dental that was used, so not traction in office. And this child had really poor posture. So she already had a really good cervical curve, but her head was really far forward. She had kind of this type of posture. And so she did exercises, adjustments, and her traction was just the cervical dental roll. And the purpose of the cervical dental roll in this case was to really just bring the head back and reduce the anterior head translation. And she only had about 1 degree or 2 increase in curve, so it was not overcorrected in her cervical curve. Her anterior head translation reduced significantly, and after 27 visits, she had, again, almost a complete resolution of her symptoms, and her asthma totally normalized. So a super cool case. Okay, this is probably my favorite of the series when it comes to the pediatrics and curve correction. Here is one that was published in the Journal of Manipulative Physiological Therapeutics. This was, and the title says it all, right? Cervical kyphosis is a possible link to attention deficit disorder. So they have a 5-year-old that was managed by drugs via their medical doctor for 3 years. And they were on Ritalin, Adderall, and Haldol for 3 years with no success. This child presented to a chiropractic office with not a lordosis, but a 12-degree cervical kyphosis. Okay, is that a problem? Yes. And so this child did 35 sessions in an office over an 8-week span. So in 2 months, they did 35 sessions with the kid, and their 12-degree kyphosis went to a 32-degree lordosis. So that's, what is that, a 44-degree correction? 44-degree correction in a matter of 2 months. What was amazing was after 27 sessions, the child's pediatrician stated that the kid no longer exhibited symptoms of ADHD. And the medical doctor also then told the parents that they no longer had to be on any medications because the child was free of any symptoms of hyperactivity disorder. Very cool case. All right, so now here is another case where all that was done with the kid was for traction, that is, a cervical dental roll. So when we're tractioning kids, my preference, I don't do any type of in-office cervical traction with kids when it comes to the cervical spine. For scoliosis and other issues, yes, but the cervical spine is so amenable to change. It's so easy to overcorrect them. I always just use cervical dental rolls with kids that need curve correction. So here's a case of a 7-year-old boy that had all kinds of spinal pain and health problems. When they x-rayed the kid, he had a lack of cervical curve. He had hyperlordosis, so too much curve in the lumbar spine, and then a pseudoscoliosis. This kid went under 21 treatments. So they did 7 weeks of care, again, adjustments, exercise, and the traction was the cervical dental roll. And the cervical curve changed from 1 degree to 21 degrees, right? Normal for that age is 23. So almost a perfect correction in 21 visits. And now if you think about it, they got 20 degrees of curve correction and 21 visits. You're almost, again, a degree per session. So changing those pediatric spines is quite easy, and it happens much, much faster than the adults. So it's awesome. I love working with kids. They're so much easier to get those beautiful corrections. The only difference is just check in sooner with them. Don't wait 6 months before re-X-raying a kid. X-ray them soon, because you might have to change. Maybe they don't need the cervical dental roll anymore. Maybe they're going from correction after 20 visits straight to wellness or maintenance. Okay, so just change your protocols a little bit for kids, because they don't need the intensity of corrective care that you'll see with an adult. But please get them in the office, get them under care, because they are a lot of fun to work with. Okay, so that is the information I had for you for the pediatric lordosis. As always, thank you very much for being on with me. And there's a 10% discount code that is valid for Warrior Docs only, WQ222. And that's for 10% off all dental roll products for the next 2 weeks or until June 14th. There's our website, my contact information, and as always, my YouTube page there if anybody wants to watch videos for how to use the dental rolls, Scoli rolls, exercises, and so on and so forth. So that's what I had for you guys. So we can open it up for questions and take some questions from the docs. Dr. Yuri, any closing comments before we close out the webinar today?
Well, only to just thank you for all the work that you do. It's guys like you that allow us to practice chiropractic with confidence with kids and adults. So just kudos to you and all the guys at CBP for bringing this to us. So thanks again.
Well, my pleasure. I'm always honored to be on here with you guys. So thank you for the invitation, and we'll see you guys next time when we talk about the lumbar lordosis.
Awesome. Thanks, Pascal.
Have a great afternoon, guys. Go get it.